Welcome, everyone. It's noon, so I'll hand it off to Evelyn Nelson to get us started today.
Thanks, Christy. Good afternoon, everyone. Really appreciate you all joining us today for the Keeping Kids Safe presentation around disordered eating. I'm Evelyn Nelson. I'm the PI for the Telehealth ROCKS program and a pediatric psychologist. Telehealth ROCKS is a federally funded program focusing on school-based behavioral health. We do this working on social determinants, supporting school-based services, and telementoring trainings, just like the one today. I just have a couple of house cleaning items that I want to remind folks of. The session's being recorded, and we'll send it to you afterwards. Your microphones have been muted, but please do use the chat and unmute to ask questions. We really want to hear from you and hear what's on your mind. Make sure that you also type in your first and last names, which I see many on the call have already done. This helps us make sure that we can track attendance and get your certificates to you. These are just some reminder slides, and none of the presenters today have any disclosures and the mitigating potential bias. This is an area that there's emerging best practices and recommendations. So today we're presenting the best that we know at the time and sharing with you best practices from a couple of different vantage points. Just a reminder, we will send the slides and recording afterwards, as well as the certificates of attendance. Please do keep in touch if you have any questions or if you have any difficulties receiving materials. With the Keeping Kids Safe sessions, we are really recognizing that it's a sensitive topic that we're discussing today. This is my reminder that, as with all our series presentations, we really support participants in choosing to participate today, or everyone is welcome to sign off at any point. With our discussions today, everyone's encouraged to consider support resources should a concern or need arise, talking with a trusted person in your environment, and also the ability, of course, to call or text 988. And our team is also available. We're here for support if there's a question or concern that comes up. So today I'm excited to share two panelists that will be sharing information with us. As you all are aware, disordered eating and eating disorders is a complex biopsychosocial concern. So we're fortunate really to have both different perspectives today. Dr. Lori Nelson, our adolescent medicine chief here in KU Pediatrics, will share with us some of the primary care and pediatrics information around disordered eating. And then Ms. Erica Mole will present for us around some of the behavioral health considerations. Erica is the Zero Suicide Program Coordinator that I believe folks may have heard on other calls from HeadQuarters Kansas. So this just gives you an idea what to expect today. I'm going to give a brief overview, really singing to the choir a bit about how important this topic is and why we're talking together today. Again, it's really thanks to this audience. It's been a topic that's been shared with us when we do our needs assessments for our echoes. So but hopefully meeting some of the need that we've heard from all of you. Our first panelist, Lori, will talk to us today about general diagnostic categories, risk factors, and how schools can help from primary care perspectives. And our second panelist, Erica, will share with us the high rates of suicide that go along with eating disorders and approaches around that. Share some about the cultural impacts around disordered eating. Share some on empathy building and giving us some ideas about creating a culture and things that we all can do together to help support students and families. So this really holds true across all our Keeping Kids sessions. But with this topic especially, I just was reminded of the unique position that school personnel, and really not just school personnel, but individuals across communities who are in a child serving role, especially we do draw a lot from schools, so that was some on my mind. Um, with this topic and others, just it's recognition that by being trusted community members, it is something that may come to your attention, and children and families may reach out or ask for help. So just understanding that we really respect that's because of the unique and trusted role that many of our audience have in schools and other organizations. There's really a lot of power in the unique perspective that school personnel and related are bringing with the ability to observe a student over time. So this isn't for all students, but with some students, we've heard from you all that you've seen them move from elementary to middle to high school. You've seen them move from one grade to another grade. So that's a real power in being able to observe, something seems different. It's not, of course, the whole diagnostic picture, but I do think it gives unique insight that if you're seeing a change, be it disordered eating, mood, or the other topics that we've covered in this series, just really using that power to kind of understand what maybe have changed over time as we're thinking about talking and supporting students and families. There's also of course, the unique perspective that school and community personnel bring, and being able to observe a student among other peers and other students, um, and really trying to have some unique insight that the behavior or what I'm seeing, it's different than what I may be seeing from other peers. Again, it's not the single factor, but it is something that's really important and useful as we're thinking about working with children and families. And then, of course, with disordered eating as the other topics, we really see that the community-based multi-person approach is so important with the prevention and intervention with eating disorders, just really setting the stage that you'll hear that throughout the talk, and it's something that we're really trying to advance with some of our Telehealth ROCKS work and other community work, that it sure takes that whole team of people to support students and families around difficult topics such as this. Next slide, please. This is also just putting an exclamation point around some of what we're talking about today. This is a really busy slide. I really just want to have one key take home. It's that there's a lot of concern that disordered eating and eating disorders are increasing. Some of that is still an evolving process. I don't have the final data on that. This is, again, what is most useful is to look at that bottom graph. And so I could put up one of probably 50 different graphs that are speaking to a similar point, where you'll see the orange line is young women, and the dark line is young men. What you see in that first part of the bottom slide is a fairly stable line of the prevalence of eating disorders. That middle section is during the pandemic COVID time period, where we saw increases in those presenting around disordered eating and eating disorder concerns. And then that final piece of the bottom graph is showing that we're still seeing that increase even post-pandemic around concerns about more youth and especially young women presenting around eating disorder concerns. Again, I don't want to rely too much on this as the final, whether it's doubled or tripled, or we don't have enough data to make a definitive statement. But the bottom line is there's a lot of concerns with our students having more challenge around disordered eating and the importance of what we're talking about today. Next slide, please. And then finally, I was surprised to read how very little information there is around eating disorder risk in rural populations, where many of our audience joins us from today. These are just some general things that have been drawn. Again, there's lots of question marks, but there is some suggestion of greater risk in rural areas, partly around some of the social determinants of health factors that many of you are working together with us and with other community initiatives to address. There's concerns around greater risk because there may be less likely to perceive a need for assistance. And as we've seen in other areas, just a lot of challenges with access to evidence-based treatment options. And there is some evidence also that our rural students are likely to experience an internalized weight stigma. Again, that set of factors and why we're talking today. Next slide, please. With that, I'll hand it off to Lori Nelson to help kind of give us some ideas from the primary care perspective and from the many years of experience in working in this area. So thank you, Lori.
Thank you, Evelyn. Okay, if you can do my first slide, please. And I just want to thank you guys all for being a part of this. And I think it's really important, as Evelyn said, you know, as a pediatrician, I see normal, healthy kids 10, 15 minutes once a year. And yeah, I've known them over time, but it's such a short period of time you see them. And you guys are, you know, as teachers, coaches, counselors, nurses, administrators, librarians, anyone involved in, you know, working with the kids, you know, on a daily basis, you just see them much more and over time. And so you're much more in tune to notice changes. I want to say, you know, and I go through all of, you know, what I'm talking about, we, you know, give you like some ideas of what you might see, but so much you will not really see anything. You might not notice, you might just even have a gut feeling that something has changed. So these are just kind of guidelines of what we talk about, and I'll give you some background, but just because your person that you might be worried about doesn't check these certain boxes, that doesn't mean that there might not be a problem. So go with your gut. Next slide, please. And again, it's important to remember that you guys are not responsible for diagnosing the eating disorder, but will play an important role in identifying students that might need help. So, you know, with a lot of things, it's not like you have to be for sure, but if you have a concern, then we need to talk about it and bring it to someone's attention. Okay, next slide, please. And this is just some facts, and kind of Evelyn went over this. Eating disorders are among one of the most deadly of all our mental illnesses and psychiatric disorders. And it's not only from a physical cause of death, but also from suicide. We often think it's usually teenagers. And so you see someone that might be, you know, in elementary school and you think, oh, they're too young. They're not. They can have the problem as well. And then it's hard if you don't have that, haven't been around the patients with this, but it's hard to understand. But really the fear of being fat is just frightening to them. And, you know, they'll say that's the worst fear they have in their life. And so I think that's important to understand, because you might be like, oh, whatever. But to them, that really is, they would, like this says, you know, worse than cancer or even losing their parent, you know, it's more worrisome than that. And so I think just to have that kind of, you know, we talk about empathy and understanding, that really is a true fear to them. All right, next slide. And these are, I'm just giving you some general like categories, and you don't need to memorize this, and they are changing constantly. It's just kind of to give you an idea. anorexia nervosa, I think everyone kind of has that picture in their mind, and it's usually someone who restricts their food. In the old days, we used to say that to be technical, you had to have lower than 85% of your ideal body weight. That's taken out. I left it in the slide just so you can see how we change. It used to be that they had to not have periods for a while. That's taken out. And so we're really constantly changing the diagnosis. And for you guys, that doesn't matter because you don't have to make the diagnosis, but all of these things kind of go together when looking at the patient. Also, if they're younger and prepubertal, just the failure to gain weight during puberty, because as you're growing, you naturally would get taller and heavier. And if you don't do that, so the actual weight per se, or loss or increase, we got to look at the whole picture. As we talked before, I think people sometimes think that when you see someone who is diagnosed with anorexia nervosa, that you think, oh, they just want to be skinny. That is not the goal. They just do not want to be fat. And that is, again, an extreme fear. And they do not want to gain weight. And so it sounds like a fine point, but once you really get to talk with people, you will realize that there is a huge difference. Also, there's often certainly a disturbance of way they look and see themselves. We all kind of laugh. You look in the mirror, and I don't know how old everyone here is, but like, obviously I don't look like I did when I'm 20, but like, we look in the mirror and think, oh, I don't look any different. I look way different than I did when I was 20. And so same way with the people that have an eating disorder, they do not see themselves the way everyone else does. So when they look in the mirror, they don't see this emaciated person. They see someone who is heavier. And so it's hard, again, if you don't experience that, to understand how can you not see this, but they don't. And so I think that's important to understand too, that they have a distorted body image of what everyone else sees. Next slide. And again, this is not important to you guys probably, but just so you know, there's different types of anorexia nervosa. There's the restrictor, and this is someone who does not engage in binge eating behaviors or purging behaviors during the last 3 months, and they just are restrictors. But you also can have anorexia nervosa with binge eating and then purging, and often people associate that with bulimia, but you also, I mean, again, it's a technical, but you could have anorexia and eat and purge. And then there are all of these, and you see where no one fits in an exact category. And I think that's what's important to realize too. We all kind of like everything to be black and white, and either it's yes or no, and with eating disorders, there's a huge continuum, and no one, or I don't say no one, very few people fit in an exact box and meet all the check boxes for each type. But overall, you can almost guarantee that through all of this, it's a very lengthy recovery and often a lifetime process, that during different episodes of their life, when things are stressful or changes, there might be a reoccurrence of their eating disorder, and they need to go back in with their therapist to work on it. Next slide. For bulimia nervosa, these are recurrent episodes of binge eating, both by eating more than a normal amount of food that you would consider normal for a period of time, and also a lack of sense of control. And that's really key to this. The person with the anorexia nervosa is a restrictor and is very controlled, and they have control over that eating, whereas the person with bulimia really feels a lack of control and they eat a lot. We often think that bulimia nervosa, they eat and then purge, but you can have other compensatory major behaviors. You can purge, some use laxative, some exercise, just to the point that it's, you can't even imagine, and especially even in inpatient units, you have to really watch them, because people will lay in their bed and be doing, crunches, or, they're very inventive. So you've really got to watch, because they will exercise continually. And then you also can use a combination of the behaviors. And again, just for a diagnosis, it has to be on the average of at least twice a week for 3 months. But again, that's, just because you did it, twice a week for 2.5 months doesn't mean you don't have it. And this is just the criteria that's needed for the exact diagnosis. But again, you still can have it. Next slide, please. And then there's binge eating disorders that, again, they eat a lot, they feel uncomfortably full, and they eat when they're not hungry, often will eat alone, but they do not have the compensatory either purging or laxative or no behavior. And so this is just I think in the old days, we didn't include this in the eating disorders, but now we realize that overeating is one of them. Next, please. And then there's avoidance of food. And again, there's all these criteria. And basically, I usually just for, unless you're really diagnosing, kind of lump them all together. There's just, some people that just restrict. And being a picky eater is different than being, a true avoidant restrictive eater. I mean, I think everyone might have something that they'd like or don't like, and that doesn't mean you have an eating disorder. But, there's the kids that you see at school that they have to bring their lunch and they will only eat the peanut butter and jelly sandwich, no crust, cut in, triangles, and 4 grapes, not 5, and, that kind of where it's very restrictive and it's very controlled. And this again can start at a very young age. Next, please. And this is kind of when you're looking for things at school. And again, I'm just going to give you some things that you might notice. But like I said before, odds are you might not notice anything that you could put it like in one of these categories. You just might have a feeling that something has changed. I think especially for those where you spend a lot, like maybe not in a class where you're just one of of 20 or 30 and you see them for an hour, you might notice it. But especially for the like clubs and teachers that are in, like, say, yearbook or coaches where you really spend a time with them and really get to know them over time, you might just get a thing, something doesn't quite seem right. And again, there's no one symptom in isolation, so it's not like you're looking for a certain thing. One thing you might notice is a decreased ability to concentrate and focus. And as if you're malnourished, you cannot concentrate, and that's important. We could do therapy, as you really have to be have some nourishment before you can even go through cognitive therapy. And you might notice just a student not doing as well. Maybe their decreased ability to engage in activities and school tasks and maybe kind of pulling out. But again, that's not 100% either. You have some that continue to get all A's in every sport and totally, functioning. That doesn't mean they don't have it either. So, but that's just one thing that you could notice. Physical signs, sometimes nausea, headache, dizziness, fatigue. Again, many patients or students will hide that and not report it. You just might notice it. Irritability, proneness to illness. So if you're really malnourished, obviously you have a weaker immune system. And the perfectionism, again, that's hard to say because just because you're perfectionist doesn't mean you have an eating disorder. And that could really be persistent or present before and after, because that personality characteristic kind of goes with the eating disorder anyway. Can you do the next slide, please? Again, you might some of the emotional changes, just maybe a change in their attitude, maybe a body dissatisfaction. And again, I'm not sure that you're going to maybe pick up on that. Sometimes it might be other students that come to you and say, depending on the relationship with you and your students. I've had some who it was actually like a friend went to the teacher and said, hey, I'm kind of worried about my friend. And, and so you might notice that, and they might have noticed it more. It may just appear sometimes to eat small portions or avoid eating entirely with others. The student that used to, always go to cafeteria for lunch, then all of a sudden is trying to figure out some activity they could do to help the teacher during lunch so they don't have to go, because it can be very uncomfortable to be in that environment for them. Sadness, depression, anxiety. And again, that's not 100%. You might have someone that just looks like they're all gung-ho and everything's great. Spending more time alone is a possibility. And then maybe a greater concern about perfectionism than before. Next slide, please. In physical signs, you might notice would be a sudden weight loss, but that's also, I mean, when you see someone every day, you might not notice that much. Maybe over the summer is a time when you would see that, when you haven't seen them for 3 months. Recurrent abdominal pain, if they're just feeling faint, if they're cold, so it's, when it was 110 and they're coming in their hoodie and gloves on, that might be worrisome. Probably you're not going to notice the hair or the dry skin. And from a physical standpoint, usually we don't even notice anything. Young, healthy adolescents, there's certain vital signs. Sometimes the heart rate's low, but most of the time you got to be really bad before you will notice something either physically on an exam or on labs, because their bodies are healthy and they can really, compensate for a lot. So don't be surprised if you don't notice that. Next slide. And then the behavioral kind of goes along with the other things we were talking about. Increased interest in food, really talking about it. I'm not sure how anyone would know what percent someone talks about food, but this is just one of the things that are listed, and you might hear them talking about it more. Again, we talked about exercising excessively, frequent trips to the bathroom, avoiding the cafeteria, bringing their own food and not wanting to go eat in front of other people. A lot of times there'll be a change in clothing. Instead of wearing clothes that fit, we'll wear really baggy clothes to cover up their body. And you think they're doing it because they're skinny and that's what they look, but they really are trying to cover up because they think they're heavy. And you might notice some increased negative verbalizations about their body. Again, though, don't be surprised if you don't. Next slide. And this is just kind of to complete what are risk factors. Again, many people don't have any of these. From biological, someone who has had a history of obesity, more likely we can see an eating disorder. Chronic dieting, puberty is a time when girls' bodies and boys too, we always think about girls, but boys too, their body changes and they don't like those changes. So that can trigger it. And there's a huge genetic, and that kind of goes along with the familial factors that if your mom had a problem or your dad, you're at higher risk of having an eating disorder. Culturally, and I think Emily's going to talk a little bit about that. I mean, there's a huge desire to be thin and to be in control, and you get peer pressure from that. And then just again, your own internal perfectionism and the external pressures to looking good are the physiological or psychological components of it. Next, please. And this is just from a variety of sources of things that schools can do. Some of them might be helpful. One is just an environment where a student feels safe. And I think it's important when we talk about media literacy and social media literacy. I think we all know that images are often altered, and it's very important for people to know that what they see isn't what that necessarily is what that person looked like. And I think that's important to early on for kids to understand that. Just looking at best practices and messaging students, we really recommend not sharing videos or information about eating disorders. There's plenty of websites that you can go to that will help you be a better anorexic, and there's chat rooms and there's support groups to learn to be a better bulimic. We don't want to tell people all that because it often can give people who are tending to have a problem, more help in their disorder. One thing that's really interesting is a lot of kids, when they see the videos on animal cruelty, that is a trigger because then they quit eating meat. So then they're vegetarian, which, a lot of kids do that for a while and then give it up. But I think it's important to not push that, because then that can often start the process of not eating meat, and then that goes to more control. I don't know, again, the age group, I'm probably the oldest one here, but when we were in PE back in grade school, all got in line, you got weighed, and you got your height taken, and it was, everyone did it. And I don't think that happens anymore, but we really encourage not to be weighed at school. And sometimes in health classes, the teachers will think, oh, let's do, calipers and measure fat for fun just to learn about it. Again, that's probably not a good idea because that's going to single out people. Really try to include students of all heights and weights and sizes and different activities, not limit that. Obviously for wrestling, that's a different ball game because, to meet the criteria, you have to get weight. So, but again, you can do that in an individual. You don't need to all line up to do that. Ensuring that the school lunches and vending machines have a variety of healthy options. And basically just being aware that students can easily be triggered by things. One of the things that I think still after years is on my mind, I had a patient who was in high school, but her eating disorder started in kindergarten when her dad picked her up and said, oh, you're getting so big. How often do we say to our kids, oh, you're getting so big? Now, again, that doesn't trigger everyone, but for her, she remembers that, and that's when it started. And so I think it's important to kind of realize what you're saying and be supportive and not maybe say things that could be taken wrong. Next slide. And again, early identification is so important for the patient or for you guys students, but for our patients that we can intervene early, the process is just so much easier, and they can really help early on and prevent it. And that's where I think the school, you guys really play a role in coming in. I think especially for coaches, like cross-country coaches, they will see a lot of patients that possibly are students that possibly could have problems. Gymnastics coaches often will. And so just be careful of those kids and just keep an eye on them. And just be sure and listen to them. And I think you guys do that, and share with us, the primary cares, that we can help with that. It really is a multidisciplinary approach. The medical part of it is a very small part. It's really the psychiatry and the psychologists and the nutritionists that really have the bulk of the therapy for eating disorders. Next slide. Before I turn over to Erica, I just want to say, and I had a slide and I don't know where it's gone, but it's talking about what you should do if you worry or concerned about a patient or a student. I'm sorry, I keep going to my role. A lot of the stuff, and I included, I think, 2 or 3 resources for you in the handouts. They all say, approach the student, talk to them. And I'm not really sure if you're comfortable doing that, maybe it's okay, but I don't really feel like that necessarily is always the answer. I think you really need to play it, per the student and how you're related to them and your relationship with them. I had spoken with several of the eating disorder teams, as well as I talked to a couple of patients, and they would have felt very uncomfortable if a teacher approached them and said, I'm worried about your eating disorder. Doesn't mean it's not the right thing to do, because it might be for some, but there are other sources. I think if you feel comfortable, that's fine. You can also go, I think sometimes the school nurses might be helpful, depending on your relationship with the parents. Sometimes contacting the parent. A lot of parents will come in and say, hey, her friend's mom came to me and said, or my son's teacher was worried. And so talking with the parent, it's just hard to know exactly how to approach it. And you'll just have to, I don't have a good answer because I don't think there's one answer to fit all. So, okay. Sorry, Erica.
All good. Thank you for sharing all of that great information, Lori. I'm Erica Mold. I'm the Zero Suicide Program Coordinator at HeadQuarters. And so we'll go to the next slide. I do look at everything through a lens of suicide prevention, of course, so we're going to start there. Lori has already mentioned this, but there is a pretty high risk of suicide among people who are diagnosed with an eating disorder. 55 to 97% of people who are diagnosed with an eating disorder also receive at least one more diagnosis of another psychiatric disorder. And so the reason I share this is because you can see that like those things are like mood disorders like depression, anxiety disorders, trauma-related disorders, substance use disorders, personality disorders, which are in large part relational, or come with like relational struggles and also are pretty much derived from trauma. And I think that the reason that's really helpful to understand is that these are all risk factors for suicide as well. So, you know, if they have an eating disorder, that's an increased risk, but also if they have an additional diagnosis, that just kind of paints a more robust picture of their risk from a psychiatric perspective. And then eating disorders currently have the second highest mortality rate of all psychiatric disorders behind opiate addiction. I think especially with the rise of fentanyl and us seeing so many fentanyl deaths, this has recently changed because before, I don't know how long ago, but not that long ago, eating disorders had the highest of all mortality rates of all psychiatric disorders. So that's really interesting, and that suicide is one of the leading causes of death for people with eating disorders. So like Lori mentioned, you know, a lot of times we think that people with eating disorders die from medical complications, and that is true. And suicide is a huge part of that, oh my God, I just totally lost my words, is a huge part of that problem. The prevalence for non-suicidal self-injury among people with eating disorders is around 28%. So when I refer to non-suicidal self-injury, I'm talking about self-harm, and self-harm behaviors are not suicide behaviors or suicide attempts. The prevalence with self-harm in people with eating disorders, it varies by diagnosis. So I think it's helpful, like I'm looking at my notes here, recent research found that people with anorexia, and that would include like atypical anorexia as well, which means that those folks with atypical anorexia are not actually underweight. They meet all criteria except for being underweight, which is the more common form of anorexia, the more common diagnosis. I think only like less than 6% of people with anorexia are actually medically underweight. So recent research has found that people with anorexia are 31 times more likely to die by suicide than the general population. Yeah. And the suicide rate for people with bulimia is 7.5 times higher than the general population. And people with binge eating disorder are 4.8 times more likely to have attempted suicide than the general population. So that's not a death statistic, a suicide death statistic, that's a suicide attempt statistic. I also think, oh, next slide, please. I also think that it's helpful to understand that we're talking about eating disorders, and it's also important to talk about disordered eating, which means like there are a lot of similarities, and that someone with disordered eating doesn't have a diagnosable eating disorder, or because they don't meet criteria, or they haven't had the opportunity to receive a diagnosis, whether that's because of stigma against help-seeking behaviors, or not knowing that they have a problem, or not, you know, not believing that they need help, etc. So disordered eating, broadly speaking, is having a problematic or disordered relationship with food, body, and or exercise. And I will say, like, our culture at large, it really normalizes and encourages and celebrates. It encourages us to have a disordered relationship with food and body. I will say also that disordered eating can become clinically diagnosable eating disorders. And again, these disordered eating is highly influenced by what's called diet culture. So we hear a lot, especially around the new year. So y'all probably have had so many ads on your social media recently around different fad diets, different weight loss injections, different weight loss products, supplements, all these things. They're really targeted marketing and all of that is like kind of encapsulates what diet culture is. So really we're just encouraged to always be thinking about our weight and to always be trying to lose weight. Next slide, please. So continuing on that note, I think it's really helpful to understand how our culture or how our society does influence eating disorder development and eating disorder like sustainment. So I think the first way to do that is to understand the experience of shame. Brené Brown defines shame as the intensely painful feeling or experience of believing that we are flawed and therefore unworthy of love and belonging. So because we're not perfect, we're unworthy of love and belonging. And shame essentially in our minds. Before I get into this, I do want to kind of add to the self-care disclosure. This is hard to talk about because all of us are exposed to this on some level. And so as I talk through the way that culture influences, I really just want to encourage everyone to take care of yourselves. I really don't want anyone to take away this message of like, you're doing something wrong, you're part of the problem. I think that so many of us exist the best way that we can and don't always know to question some of the things that we're being kind of influenced by. So this isn't to shame anyone. So anyway, so sometimes shame in our minds sounds like I'm not good enough, I'm not pretty enough, I'm not thin enough, I'm not smart enough, I'm not strong enough, like those types of messages, like I'm not fill in the blank enough, or I'm too much, I'm too fat, I'm too loud, I'm too emotional, those types of messages. Those are shame tapes, basically. And we live in a culture of shame. We live in a culture of a lot of things, and one of those things is shame, I should say. We live in a culture that uses shame to exploit and enable toxic relationships with food, body, and exercise, and those things kind of I've already mentioned around like we're told that our bodies aren't good enough, we're never eating healthy enough, we're never fit enough. And we're literally sold products products and fad diets and cleanses and detox campaigns and exercise programs and different things like that, cosmetic enhancers, those types of things, many of which aren't scientifically proven to benefit overall health and well-being. That's not to say that all of them aren't, because some of them are medically proven to help with weight goals, and we're encouraged to engage in a lot of things that are actually unsafe. I wanted to respond. In our Hispanic culture, we are thought to have a very close relationship with food and then be shamed when we're too heavy. That's so complicated, yes. And to be clear, like when I say culture at large, shame and the culture of shame looks different when it's intersected with other cultures as well. So it's definitely not the same for every single person. And then in general, I think it's helpful to understand that like our societal value system, like our society connects a person's worthiness to the size of their body, and we specifically value thinness. And so that's where some of that weight stigma comes into play. We're taught really to betray our own minds and bodies kind of at all costs, so long as we can achieve a smaller body size. And we're encouraged to prioritize thinness over mental and physical health a lot of times. And again, I'm not saying every single person in our lives is encouraging this. I'm saying like media, for example, is encouraging this. Can we go to the next slide, please? I think it's helpful to kind of look at this image. This is just like a very simplified, broken down depiction of kind of the development of an eating disorder. And I think it's helpful to see how our culture plays a role in the development of an eating disorder, because the first part of eating disorder development is developing a negative body image. And our culture is the thing that one of the main things, I should say, that influences our perception of ourselves and our body image in general. The next thing is you kind of escalate to having a lot of intrusive thoughts around food and body and exercise and weight and space and just all of these really intrusive thoughts that take up a lot of time and energy. And then it kind of, like an eating disorder, kind of peaks at starting to engage or sustaining engagement in eating disorder behaviors, which this is not the space to go into that. And then I'll talk about like what happens when we start recovery. I'll talk about that in a little bit, but I just wanted you to see kind of the full picture of what the development of an eating disorder looks like. Next slide, please. So just to kind of clarify some of the things that you saw on the slide, body image is thoughts, perceptions, and attitudes about one's physical appearance. That includes size, shape, and weight, and the experience of one's own body. So how comfortable are you in your body? How much space do you perceive your body to take up? Those types of things. And a negative body image or body dissatisfaction essentially includes symptoms like perceptual distortions, like Lori was talking about earlier. Like you look in the mirror and you see something that's not accurate. Body hatred is a very big part of the eating disorder experience. Shame, anxiety, dissociation, those types of things. And then intrusive thoughts are obsessive thoughts about food, body, and exercise. So some examples of that, and these come from my own lived experience mostly as a person who's in recovery from an eating disorder. I'm not recovered, but I have been working in recovery for a long time. And I've been in eating disorder groups for recovery. So this is kind of all informed by that experience, this part in particular, but there's a lot more nuance to this as well. So when we're talking about intrusive thoughts about food, it's like, what do I eat? When do I eat? How much do I eat? What food is safe? What food is unsafe? What food is good? What food is bad? This is when we get into like categorizing foods. There's a lot of food rules in the mind of a person with an eating disorder, and those categories include good food versus bad food, healthy food versus unhealthy food. And I can tell you, every single person on this call is going to have a different answer about what they consider to be healthy versus unhealthy or good versus bad. And that is totally informed by just how you were raised and your own like lived experience. But there is no rhyme or reason to how we categorize foods as healthy versus unhealthy in our culture. So that's a whole other soapbox that I'm not going to stand on for the sake of time. And then thinking about body, like how much space am I taking up? Is my body touching the door jamb? Is my body touching another person? How can I make myself smaller? How much do I weigh? How many calories have I burned or lost or whatever? Like things around numbers and commands as well. Like you can't eat that. You can't eat that. You have to exercise. You have to exercise. It's really, really intense. And then also there's a lot of like fixation around clothing. Like you might notice someone with an eating disorder really is constantly kind of moving their bodies and readjusting their clothing. And it's just generally uncomfortable in their body. And then exercise, they're really focused on how long, how far, how many reps, what's my max, how calorie intake versus calories burned, height, frequency, that type of stuff. Like it's what counts as exercise. Walking might not count in the mind of someone with an eating disorder, although we know walking is really good for our hearts, right? Like, so it's just very distorted and very intrusive. And then disordered behaviors are strategies used to cope with concerns about food, body, and exercise, and they're typically driven by shame, anxiety, fear, overwhelm, and this one I think is really important, desperation. When Lori was talking about how people are more afraid to be fat people with eating disorders are more afraid of becoming fat than they are of like dying from cancer or losing a loved one. It is a desperate feeling. Like it is I want to crawl out of my skin feeling because I hate my body so much. It's so wrong. It shouldn't be like this. I have to change it. I have to change it. I have to change it. That it's really intense. And so that feeling often guides a lot of behavior, especially compensatory behavior, which Lori had talked about the varieties of compensatory behaviors. but and then also will drive like restriction as well. And I will say too, eating disorders can be really rigid and routine and like ritualistic almost, but they can also be really chaotic and impulsive. And I think that we don't always understand that both of those things can be true, even at the same time for the same person, right? Like I have experienced both rigid and routine and chaotic and impulsive symptoms with my eating disorder. Next slide, please. So some other components of the eating disorder, intrinsic motivations. People engage in eating disorder behaviors because they want to feel in control. They want to feel safe. They need to regulate their emotions. They want to feel socially accepted. These are just a few of many reasons why an eating disorder will persist. But again, I think that that's really helpful to understand. Like when we talk about eating disorders not being a choice, like what that means is that people need to use these behaviors in order to achieve some semblance of safety, some semblance of control. And I think that that is, especially when we're talking about youth, they don't have a lot of control or autonomy in their life, right? And so this is a way that they can have control over their own bodies. Also talking about people who have been like, experienced some type of like body-based trauma, so physical, sexual abuse type of stuff. This is a way to take back control of their body when they didn't have any control over what happened to them. Like I said, our culture really influences our belief system. These things are like conditioned and internalized, but it's like belief in the way that like folks believe in a higher power. Like these things are true. You can't argue. Like you can't tell me otherwise. It's like capital T truth. And their self-worth is directly tied to the values around food, body, and exercise. And the other main component that I think is really important is the element of suffering. There's physical suffering, mental suffering, emotional suffering, and social suffering. Feelings that I've already mentioned that you see on the screen are often present and are feelings that are associated with suffering, right? The other thing that people don't always understand about eating disorders that I think is really important is the element of grief and loss. Eating disorders steal our time, energy, and focus. They take up so much space in our lives. They isolate us from relationships, especially if we feel the need to keep our eating disorders a secret or to keep our behaviors private so that no one's holding us accountable. And they limit our participation in our own life, especially when we have body distortions or a negative body image. How many, I can't tell you how many times I chose not to go to the lake because I didn't want anyone to see me in a swimming suit, or how many times I was wearing full clothing in the dead of summer when it's so hot outside because I was so afraid of being seen as fat. And so when I say they limit our participation in our own life, one of the things that I have had to kind of come to terms with now that I have a child is like, I want to go to the pool and play and swim with my kid, even if that means I have to wear a swimming suit in public, right? Like I have to make that decision about my value system. What's more important to me? Is it how I look, or is it how the kind of childhood I give my kid, right? And it's not that simple for everyone. And it's not easy to make those decisions. It sounds like obviously you would choose your kid, but that's not how it feels. It feels really, really scary. So next slide, please. I do want to just say, when recovery starts, after medical clearance takes place, then recovery starts with changing behavior and like working to eliminate the eating disorder behaviors. And that is really hard because, again, all of the reasons that I've talked about, like eating disorder behaviors are the thing that make people feel safe and in control. And if we are asking them to give those things up, then how are they supposed to feel safe and in control? So a lot of people are really afraid to engage in recovery. And it's super important that that's the first thing you do. And then you tackle intrusive thoughts. And then you're tackling negative body image. But all of these things, and some of it you're kind of doing at the same time. But this is kind of oversimplified. But I just think, like, imagine living in this world and trying to recover from an eating disorder when our culture is just building this foundation of negative body image all of the time. So recovery is hard and it takes a really long time. Next slide, please. Some of the things that I think are really helpful for you all to know, and for especially for school personnel to do, is to educate students about eating disorders and body image issues to increase awareness, combat stereotypes, and decrease stigma. And to do that in a safe way, right? We don't want anyone to see depictions of emaciated bodies, and that's the type of education that they're getting. It's just kind of a safe way of education. And there are some resources in the resource slide that y'all can look at to be able to provide that education. But studies have shown that especially when students are educated about body acceptance and educated about the risks of weight control behaviors, then they're much less likely to engage in an eating disorder or to develop an eating disorder. So I think that's really, really cool. And then identify school policies that promote the thin ideal and advocate for size inclusive policies in curriculum instead. Again, there are resources in the resources slide to address some of that if you have questions. And then it really comes down to like combating weight stigma. So how do we create a new culture? How do we combat the culture that we live in around weight stigma? So how do we create an environment where students of all shapes and sizes feel safe and accepted? The first thing is that we have to be accountable for that, right? It's my job to be a positive role model for my child for body acceptance and a balanced relationship with eating. So I'm not allowed to talk poorly about my body in front of my child, for instance. I also have to eat when my child eats so that she can see that it's normal and appropriate to eat food. So thinking about ways to be a role model, there are some tips for that on the upcoming slides. Pay attention to how students and staff are talking about bodies, nutrition, exercise, and eating, and intervene when necessary, especially if someone is being bullied for their weight. That is a huge risk factor in the development of an eating disorder. So we have to examine our own attitudes about body, and we have to be willing to kind of start normalizing these other things that aren't usually normalized. Next slide, please. I know we're getting really close on time. So this slide just shows you some examples of what you can say if you hear someone talking about, like, I weigh this much, or, oh my God, I've gained this many pounds, or talking about like counting calories or nutrient tracking. You can say, you know, we actually don't find that talking about numbers is useful. It's actually more hurtful more harmful than it is helpful. So really like being able to speak to that publicly, I think is so like demonstrating that like new culture and trying to normalize that. Anytime someone's talking about diet, we just want to reiterate like good food, bad food, etc. Food is just food. We all get fuel in different ways. Every person's body needs different or has different needs. We want to make sure that like if you're not a nutritionist, that you're not giving dietary advice or opinions, because it's so misguided, it's so misinformed. The stuff that we find on the internet is so contradictory to a lot, like to itself even. Everyone has an opinion about what's healthy and unhealthy, and it's going to differ depending on who you ask. Avoid discussions of fad diets and avoid labeling or categorizing foods. And then also reframing exercise to say like moving our bodies is a way to support our overall health and well-being. It helps our hearts, muscles, and minds, right? Like it's not just about getting a smaller body. It's also about taking care of our mental health, our heart health, our muscular health, etc. And we want to avoid like categorizing what counts or doesn't count as exercise. And we also want to avoid offering guidance around the kind of exercise regimen that will support a person's weight goals. And I know that like it's tricky for coaches because your job is literally to create the exercise regimen, and that's totally fine. It's just that exercise regimen shouldn't be about weight, if that makes sense. Okay, I think I'll next slide, please, just to see what it is. I don't remember. Oh, this is the last one. So body acceptance and body neutrality. I highly recommend like reading about that just so y'all and just kind of looking over this slide since we're out of time. But I think it's really helpful to understand the difference between body acceptance and body neutrality, and then to kind of work towards normalizing some of these things in the school environment. I'll stop there.
Thank you, Erica, and thank you also, Lori. So many great takeaways. I'm not going to go through every takeaway. I just want to reinforce that last message and Lori's message of there's a lot of hopeful things we can all do together. You both have given us many great ideas around how that may look. The key takeaways really touch upon that. I'll turn it over to Christy. I know she's going to set us up for our next echo and what to expect.
Thank you. Thank you both for tackling such a difficult topic. We appreciate the compassion and the information that you shared today. Thank you to everyone for joining us. We will send the slides as a follow-up and follow-up materials to your email, including the key takeaways and the resource links. We hope to see everybody at the next session on March 6th at noon. This will be the last session, and we'll discuss protective factors that can span all the topics in this series, as well as how to support students over break. So thank you so much, everyone. We hope you have a good afternoon.